¿Qué tal? Muy buenos días a todos. Es un gusto nuevamente estar aquí en la edición número 23 del Foro Internacional de Medicina Crítica en la Ciudad de México, en su primera edición virtual. Y este sería el tercer módulo donde estaremos con profesores de gran valía, como han sido los dos módulos anteriores, el doctor Andrés Esteban,
Ya lo he quitado.
el doctor Luciano Gattinoni, Christa Schorr, Phillip Dellinger. Y bueno, vamos a empezar con la primera presentación del día. La primera presentación del día corre a cargo del doctor Andrés Esteban. Andrés Esteban es ya alguien que ha estado anteriormente en otros espacios con nosotros en este foro. Andrés Esteban ya es un invitado ampliamente conocido. Él es licenciado en Medicina y Cirugía en la Universidad Complutense de Madrid. Es doctor en medicina también por la misma institución académica y ha pertenecido a varias sociedades médicas, entre ellas la Sociedad Española de Medicina Intensiva y Cuidados Coronarios, la Sociedad Española de Calidad Asistencial. Y bueno, es autor además de 253 artículos originales en revistas con peer review, con un índice H de 77, y ha sido también coordinador de la red Gira, así como jefe del grupo 23 del CIBER de enfermedades respiratorias. Ha participado además también como miembro del board de las conferencias del Consenso Americano Europeo para Retiro de la Ventilación Mecánica, así como también el Consenso Americano Europeo de CIRA, y sus líneas de investigación están centradas primordialmente en lo que es ventilación mecánica, retiro de la ventilación y CIRA. Es una persona que, bueno, tiene una amplia bagaje curricular y queremos cederle la palabra con su charla que ¿Es la obesidad un factor pronóstico? Adelante, doctor Andrés.
Buenos días en México, buenas tardes aquí en Madrid. Espero que tengan ustedes una temperatura mejor que la que tenemos nosotros aquí ahora con 37 grados. La verdad es que siempre que estoy en México, que me tratan maravillosamente, esta vez solo voy a estar 30 minutos en México y además una manera de estar un poco peculiar, pero espero que en el futuro los motivos que han hecho que esta reunión sea hecha de manera telemática se solucionen para todos y podamos volver a estrecharnos la mano en México en un futuro relativamente pronto. El tema es la obesidad. La pregunta es si es la obesidad un factor pronóstico y, digamos, la obesidad, como ustedes saben, es un tema en auge, es un tema que cada vez es más importante y, de hecho, en esta diapositiva de un estudio hecho en el National Health Service y que estaba hecho hasta el 2003, pero del 1993. Y fíjense los pacientes que tienen índice de masa corporal superior a 40, es decir, los obesos mórbidos, en una población ni joven ni anciana, sube espectacularmente y ha ido evolucionando muchísimo. Dice, pero ¿cuál es la importancia de esto? Aparte de la parte estética y de otra serie de factores. Hay un estudio en England que está hecho para monitorizar pacientes fumadores y entonces, bueno, realmente sí que vale la diapositiva, puesto que tienen en este eje índices de masa corporal desde menos de 12,5 hasta los obesos mórbidos y fíjense que en esta franja es donde la mortalidad es más baja. La mortalidad sube a medida ellos se encuentran en una población general, no es de cuidados intensivos, es una población absolutamente sin ninguna característica especial y sube en los obesos mórbidos, pero también, curiosamente, sube en los pacientes con un índice de masa corporal bajito. O sea que parece que a juzgar por esta diapositiva no debemos estar muy gordos, pero tampoco demasiado delgados. Hay un estudio publicado en Chess en el 2007 con la clasificación típica de los diversos niveles de índice de masa corporal y que lo que encuentran es concretamente es infrapesos, y sobrepeso, obesos y severamente obesos. Y fíjense que si en el tiempo de estancia en el hospital es mayor en los obesos, tanto en los supervivientes como en los no supervivientes, pero, por ejemplo, cuando hablamos del tiempo de estancia en cuidados intensivos, aunque es mayor, esa diferencia no es significativa. La duración de la ventilación mecánica hay diferencias, pero claramente no son significativas. Y lo que en principio pudiera llamar más la atención es que la mortalidad no es diferente estadísticamente significativa. De hecho, los severamente obesos es más alta, es más baja la O-ratio, es decir, que aunque no hay diferencias, sí algo podría ocurrir es que los obesos en este estudio tienen un índice de fallecimiento menor. En otro estudio publicado en Thorax en el 2010, en pacientes que en un estudio epidemiológico de distrés respiratorio, ellos veían que la odds ratio, o sea, el riesgo de desarrollar distrés respiratorio, era en los severamente obesos más alto y también en los obesos. Eran los dos grupos en los que el riesgo de desarrollar distrés respiratorio en pacientes con ventilación mecánica era más alto. Pero cuando mirábamos el riesgo de la mortalidad, en la mortalidad en los 4 grupos estos no hay diferencias significativas. Es un rango muy alto, pero a pesar de que digamos, la mortalidad parece ser que es un poquito más alta, pero esa diferencia no es significativa en los pacientes. Por tanto, digamos, tienen más riesgo de hacer distrés en este estudio, pero no se conlleva eso un riesgo de mortalidad más alto. Aquí en esta publicación de nuestro grupo en el 2011, en que participaban, como en casi todos los estudios de ventilación mecánica internacionales que hemos llevado a cabo en unidades de cuidados intensivos de México, pues, digamos, hasta la distribución, había un 4% en los severamente obesos de ese estudio, pero fíjense, la distribución era esta, y fíjense que los obesos en el estudio 2004 era el 15,9, había subido ligerísimamente en el 2010, y los obesos mórbidos, los de índice de masa corporal superior a 40, se estaban, parece, estabilizados en un 4%. Bien, entonces, cuando lo miramos por áreas geográficas, aquí es la distribución, pero simplemente le vamos a prestar atención a los obesos y a los severamente obesos. En Latinoamérica, 11 y 2,1. En Europa, muy parecido, 13,5 y 2,9. Y en otros países, en el cual está Arabia Saudí, Turquía, Túnez, 19 y 2,5. Lo que es espectacular es la diferencia en Estados Unidos y Canadá. En los obesos un 23,6 y en los muy obesos estos son prácticamente 3 veces más que lo que ocurre en el resto del mundo. Ahora en el estudio que acabamos de publicar hace 3 meses, que es el 4º estudio internacional de ventilación mecánica, en el que se aunan los 4 estudios, fíjense que en el estudio del 2010 y el 2016 ocurre prácticamente lo mismo. Digamos, no ha cambiado prácticamente en ningún país los severamente obesos, salvo en Estados Unidos, que ha pasado del 10 al 14, y que tanto los obesos en el 2016 y el 27 como los muy obesos el 14 realmente son cifras extraordinariamente altas en este área. Dice, ¿y eso qué importancia tiene desde el punto de vista de ventilación mecánica? ¿Cómo ventilábamos los enfermos en el 2010 en este tipo de pacientes? Pues fíjense que cuando lo calculamos, las cifras con el peso por mililitros por peso actual, entonces fíjense que en los pacientes obesos les ventilamos con 6,5 mililitros por kilogramo de peso, que es muy bajo, estaría absolutamente dentro de las recomendaciones de cómo hay que manejar los pacientes, y los severamente obesos el 5. Pero si le prestamos atención al peso predicho, que es con lo que hay que calcularlo, no solo es que está dentro de los límites, sino que está muy lejos. Y estamos ventilando a los pacientes con 10,1 y con 11,1 mililitros por kilogramo de peso. Y eso no solo ocurre en los pacientes el primer día, sino que el día 3 se vuelve a repetir el mismo fenómeno, calculado desde el punto de vista del peso actual, 6 y 5 en el día 3 y 6 y 5 otra vez en el día 7. Pero de nuevo, cuando lo calculamos con el peso predicho, que es con lo que hay que calcularlo sin ninguna duda, pues resulta que estamos muy altos, muy lejos, muy mal la ventilación de nuestros pacientes cuando ventilamos a los pacientes, que lo hacemos, parece ser, teniendo en cuenta el peso actual, pero no el peso predicho. Con el peso actual lo hacemos bien, lo cual es una falacia, pero con el peso predicho lo hacemos realmente mal y estamos agrediendo a los pacientes. ¿Qué pasa y qué importancia tiene eso? Y dice, pues mire, que cuando vemos en estos pacientes las complicaciones durante la ventilación mecánica, no hay ninguna significativa salvo 2, que son que producen más distrés en los pacientes obesos y muy obesos y producen más insuficiencia renal, o les producimos más insuficiencia renal en los obesos y muy obesos. Entonces, no es banal lo que estamos haciendo. Pero además de paso dice, ¿qué es lo que pasa? Dice, pues que miren, esto es una tomografía axial computarizada de un individuo normal, en el que lo que ventilamos con esos mililitros es esto, cuando ventilamos de acuerdo con el peso predicho, es decir, con el peso que tiene que tener, en este caso, el actual y el predicho son prácticamente el mismo. Pero, ¿qué hacemos con este paciente? Que hemos tenido que ampliar la diapositiva y que no es un paciente, como hemos visto antes, extraordinariamente infrecuente, un paciente muy obeso. Claro, lo que estamos haciendo, a juzgar por los números esos, perdón, es que estamos ventilando todo esto. Cuando hacemos el cálculo del volumen circulante, lo hacemos con el peso actual y no calculando con el peso predicho, que sería que ventilásemos lo que queremos ventilar, es decir, los pulmones. Por lo tanto, estamos haciéndolo realmente mal en líneas generales en este tipo de pacientes. Y eso, digamos, un poco en un estudio sobre asociación con variables de desarrollar distrés respiratorio en pacientes que no tenían nada al principio de la ventilación mecánica, los pacientes que desarrollan distrés posteriormente son los pacientes que habíamos ventilado con volumen tidal alto, frente a los que no lo desarrollan, que es los que les habíamos ventilado con volumen tidal normales. Y lo mismo ocurría con la presión pico. Bien, entonces, dice, y eso por ahora lo que vemos es que estamos, a juzgar por estos datos, ventilando a los pacientes calculando su peso actual, no su peso predicho, es decir, estamos ventilando los pulmones y la grasa en lugar de los pulmones exclusivamente, dice, y producimos más distrés y más insuficiencia renal, a juzgar por esos datos. ¿Y qué pasa con la mortalidad? Bueno, pues la mortalidad, sorprendentemente, digo sorprendentemente porque parecía que lo estábamos haciendo muy mal, la mortalidad no es diferente. No es diferente entre los pacientes normales y con sobrepeso frente a los obesos y muy obesos, y como ven la P, que muestra la diferencia entre los distintos grupos, la mortalidad no es significativa claramente, y la mortalidad en el hospital, aunque está más cerca, pero también sigue sin ser significativa. Es decir, que lo estamos haciendo mal, que les producimos más distrés, que les producimos más insuficiencia renal, pero que no se mueren mal. Nosotros hicimos un estudio con esto, con la base de datos, como era muy grande, nos permitimos hacer un estudio de casos apareados y comparamos 1.008 pacientes que tenían índice de masa corporal menor de 30 frente a otro grupo igual, apareado para todas las variables, con masa corporal menor de 30. Las variables que se aparearon fueron la misma edad, el mismo sexo, la misma severidad, medido por SARS-2 y la misma razón para ventilación mecánica. Y entonces nos encontramos con que, evidentemente, el apareamiento era correcto y la única variable que era diferente, las demás eran prácticamente idénticas, era el peso. Es decir, el índice de masa corporal de 31 en los obesos, 37 en los obesos, frente a 24 en los no obesos. Esto era parte del diseño, no hay ningún problema. ¿Y qué pasaba? Dice, bueno, pues otra vez, en los pacientes con obesos producíamos, o se producía, yo creo que los producíamos, un 7% de distrés respiratorio frente a un 5% de los no obesos, y esa diferencia era significativa. Y lo mismo ocurría con la insuficiencia renal. 23% de insuficiencia renal en los muy obesos frente a un 18% en los no obesos. Y otra vez más era significativa. Y los demás variables no eran diferentes significativamente. Y entonces, cuando hacemos el análisis univariante y multivariante, pues resulta que vemos aquí que las variables, que estas dos no son significativas, las dos únicas que en el multivariante se mantienen y son significativas, es decir, que tienen importancia independientemente de todas las demás, son la presencia de obesidad y la presencia de obesidad mórbida. Y esto es para el desarrollo de síndrome de distrés respiratorio durante el curso de la ventilación mecánica. Es decir, que a nuestros pacientes obesos, en general, les estábamos agrediendo, ventilándolos en base al peso actual y no al peso predicho, y les estábamos produciendo más distrés respiratorio. Bien, pero la mortalidad, dice, otra vez ocurre lo mismo que nos ocurría cuando veíamos la tabla general. En este, que era un estudio con casos apareados y por tanto mucho más fiable, pues resulta que la mortalidad en cuidados intensivos y la mortalidad en el hospital, como pueden ver, 28, 30, 33, 36, y no son estadísticamente significativos. Es decir, que a pesar de los esfuerzos, y lo digo entre comillas, obviamente, por agredir a los enfermos con nuestra ventilación mecánica, no se mueren más los enfermos obesos y los no obesos en la unidad de cuidados intensivos. Este es el estudio, el cuarto estudio internacional de ventilación mecánica, que nosotros acaba de publicarse hace 2 meses, en el 2020, justo al principio de la pandemia, y que quiero mostrarles cómo evoluciona la proporción y la mortalidad en cuidados intensivos de los pacientes con infrapeso, los normales, que sería la referencia, los de sobrepeso, los obesos y los muy obesos. Y como ven, la mortalidad es prácticamente la misma en todos los grupos. No hay diferencia significativa entre los grupos. Y cuando lo hacemos tratando la mortalidad cruda, que es el azul, que es el que acabamos de ver ahora, y lo hacemos ajustada para la edad, el sexo, la gravedad, el motivo de ventilación mecánica y soporte ventilatorio inicial, era o con ventilación no invasiva inicialmente o invasiva, entonces vemos que, aunque aquí es un poquito más alta la odds ratio de los pacientes, una vez que los hemos ajustado, esta diferencia tiene una P de 0.273, es decir, que no es significativa. Es decir, que nuestros pacientes siguen sin morirse más los pacientes severamente obesos y los obesos, que están con ventilación mecánica. Y ahora prestamos atención o tratamos de buscar datos en los estudios publicados sobre el COVID-19. El primero grande, que hay dos en este momento con un volumen de pacientes muy alto, es el primero hecho en Italia, el publicado en el JAMA hace 2 meses, en el 2020, y que no prestan atención o no aparecen en los datos el tema del índice de masa corporal. A pesar de que durante un cierto tiempo, por lo menos en los medios de comunicación, que han sido los más activos, sin duda, en transmitir información, se consideraba que los pacientes obesos eran pacientes de muchísimo más riesgo que los pacientes no obesos en este tipo de problema. Y entonces, el otro estudio es el que se ha hecho en la ciudad de Nueva York, un estudio prospectivo, publicado también en el Lancet, pues me parece que hace un mes, una cosa así, que salió publicado. Y entonces, fíjense que en análisis univariante y en análisis multivariante hay una serie de variables que están en el univariante, pero sobre todo en el multivariante, y esto es lo más importante, porque cada una de estas es que tiene una odds ratio de 1.13 o una odds ratio de 1.31, que significa que tiene un 31% más posibilidades de morirse que si tiene esa variable, independientemente del resto de las variables. Pero lo que yo les muestro esta diapositiva es que el índice de masa corporal, que parece que disminuía el riesgo de morirse en el univariante, desaparece en el multivariante. Es decir, que no tiene trascendencia desde el punto de vista de modificar el riesgo de morirse de estos pacientes en base a ese dato. Es un estudio observacional, pero tiene un volumen de pacientes alto que permite que esto tenga una cierta posibilidad de ser bastante real. Yo, con motivo de esta charla, he consultado en la página web de la Sociedad Española de Medicina Intensiva. Tiene publicada una página web que se actualiza periódicamente del grupo de trabajo de enfermedades infecciosas y sepsis. Y entonces, en ese momento tenían 1.742 pacientes con COVID-19 ingresados en las unidades de cuidados intensivos, concretamente en 55 de las unidades de cuidados intensivos. Es un número relativamente pequeño de las unidades totales que hay en España de cuidados intensivos. La edad media era 64, como es una mediana, 64, el percentil 25, 75 y el percentil 71, el percentil 75, 71. El Apache 14, también con percentiles de 10 y 18, perdón. Entonces, los supervivientes eran 1.171 en ese momento y fallecidos 571. Bueno, pues si tenemos en cuenta la obesidad como un factor, es prácticamente superponible en los pacientes supervivientes que en los pacientes que fallecen. Esto es un dato, no queda más remedio, como la mayor parte de la información que estamos recibiendo en este momento sobre la epidemia del COVID-19, que son todos datos provisionales, deprisa y corriendo, pero que valen para pensar que en el COVID-19 está ocurriendo prácticamente lo mismo que ocurría en la población general sometida a ventilación mecánica. Y hace 5 meses, ha sido en el Critical Medicine, se ha publicado un artículo que era un grupo de pacientes que tenían, que trataban de averiguar si la obesidad era un factor protector o agravante en los pacientes con sepsis. Y miran 55.000 pacientes de 139 hospitales en los Estados Unidos que tenían sepsis. Bien, la distribución es más frecuente, más de 40, el 9%, es del 4% nuestro, pero muy próximo a los datos del estudio internacional correspondiente a Estados Unidos, es decir, que es el 9, el 10% que tenían. Y lo que yo quiero mostrarles es que en análisis multivariante, fíjense que la odds ratio, que parece que aumenta en un 62% el riesgo de fallecer en los pacientes con infrapeso, que este es el punto de referencia a los pacientes de peso normal, pero fíjense que a medida que sube el peso, parece que los pacientes disminuyen el riesgo de fallecer por un episodio de sepsis, hasta el extremo de que, en este caso, la disminución es muy importante. Bueno, en el obeso también. Son los pacientes con sobrepeso, con obesidad y con obesidad mórbida, tienen menos riesgos de fallecer si tienen una sepsis, a juzgar por los datos de este estudio. Por tanto, digamos un poco, ¿qué es lo que pasa? Dice, pues que obviamente lo que el paciente obeso tiene más adipocitos. Y los adipocitos y tienen también más colesterol. Los adipocitos producen adipoquinas que inhiben la producción de TNF, la de IL-6 y la IL-8 y una serie de variables también distintas. Y producen leptina. Pero además, el adipocito el colesterol es un atrapador de endotoxinas, con lo cual el paciente obeso parece que está mejor dotado para resistir las agresiones que producen factores TNF, interleuquina 6, interleuquina 8 y la propia endotoxina. No podemos olvidar de que cuando estamos en presencia del COVID-19 tenemos al paciente con distrés respiratorio, pero lo que tiene el paciente inicialmente es una infección por virus, pero una infección. Entonces, si ahora en el descanso, a juzgar por estos datos que yo les he contado, pueden ustedes tomar todo lo que se ofrezcan. Me temo, y no quiero molestar al doctor Gutiérrez, que el descanso no tiene esa maravilla, pero si lo toman, no hay problema, sobre todo si hacen un poquito de ejercicio. Pero cuando el doctor Gutiérrez, mi amigo, el doctor Gutiérrez, digo mi amigo porque en la invitación a esto, que siempre es un halago y que estoy encantado, pero que ha sido un pequeño atraco y además para mí cronológicamente no ha sido bueno, porque dentro de 15 días yo tendría información para poder aportar mucha más información del COVID-19. Tenemos una serie de pacientes ventilados durante más de 48 horas, son más, pero cuando se ha depurado la base de datos, tenemos 868 pacientes con ventilación mecánica más de 48 horas debido a una infección por COVID-19. La obesidad, el 31% de los pacientes son obesos. Pero fíjense, estos son datos preliminares no ajustados, y tenemos dos grupos, índice de masa corporal menor de 30 e índice de masa corporal más de 30. Todo esto son datos que hemos sacado deprisa y corriendo porque en este momento se está empezando a analizar la base de datos y era un momento incómodo de hacer. Pero fíjense, la mortalidad en cuidados intensivos de los pacientes, digamos, no obesos, 38. La de los obesos, 32. La mortalidad del día 28 es prácticamente la misma, pero si me permiten, es ligerísimamente menor la de los obesos. El día 30, la de los obesos y los no obesos es más diferente y esa mortalidad el día 90 se mantiene también bastante diferente. Son datos no ajustados, son datos, como les contaba, sacados de prisa y corriendo para podérselos mostrar a ustedes, pero que lo que parece es que coinciden mucho con los datos que tenemos de pacientes con ventilación mecánica por otras etiologías. O sea, que parece que no se está comportando distinto en este sentido, ni de los datos que venían de la sepsis, y no dejan de ser una infección por virus, y los datos de los pacientes sometidos a ventilación mecánica. Por tanto, como conclusiones, es que un número significativo de los pacientes que reciben ventilación mecánica, y no es una excepción, la ventilación mecánica que reciben los pacientes afectados de COVID-19, tienen un peso corporal elevado. Más del 25% en el COVID, como acabamos de ver en los datos que se muestra ahora, el 31% de los pacientes son obesos o muy obesos. Los pacientes obesos, y esto desgraciadamente lo ponía en los datos del principio, son ventilados con un volumen circulante elevado porque lo hacen basado en el cálculo con el peso actual, no con el peso predicho, es decir, con el peso que tendría que tener si el enfermo no fuese obeso. Y por tanto, los pulmones que no suben o bajan en virtud de la obesidad del paciente es una cosa que tenemos que tener muy metido en la cabeza. Nosotros ventilamos los pulmones, no ventilamos la capa de grasa del paciente. Esto se acompaña, como hemos visto, de complicaciones significativas durante la ventilación mecánica, tales como el distrés respiratorio o el fracaso renal. Y, sin embargo, a pesar de todo, no hay una asociación entre la obesidad y un incremento de la duración de la ventilación mecánica, el tiempo de estancia y, sobre todo, no hay una asociación con la mortalidad. Y si la hay una cierta tendencia, por ahora, les mostraré, cuando nos podamos ver en un futuro, espero que no muy lejano, ya tendremos los datos del estudio este que les he referido y que está siendo analizado en este momento. Pero si hay algo que ocurre, es que los pacientes con obesidad no solo no van peor, sino que tienen cierta tendencia, y lo digo recalcando y con cuidado lo que estaba diciendo, cierta tendencia a tener menor mortalidad. Por tanto, dice, la pregunta al principio, ¿Es la obesidad un factor pronóstico en los pacientes con ventilación mecánica? Bueno, pues hay dos contestaciones. Una, si el médico responsable conoce los principios básicos de la ventilación mecánica y sabe que cuando calculamos el volumen circulante de un paciente hay que hacerlo por mililitros por kilogramo de peso predicho, entonces la obesidad no es un factor pronóstico. Pero si el médico que le trata no conoce los principios básicos de la ventilación mecánica y ventila al paciente con un volumen tidal ajustado al peso actual, entonces sí que la obesidad es un factor de pronóstico. Pero podemos concluir que lo que es un factor pronóstico no es la obesidad, sino los conocimientos del médico que trata al paciente obeso. Muchas gracias.
Muchas gracias, doctor Andrés Esteban, por su intervención. Tenemos aquí algunas preguntas. Vamos a empezar a revisar las primeras. Nos preguntan, doctor, dentro de la primera serie, de las series que presentó aquí en uno de los slides, ¿qué fórmula utilizaron para hacer el cálculo del peso predicho para la ventilación mecánica?
Hay una fórmula de altura y peso que es la superficie corporal. Entonces, yo creo que, no, vamos, ahora mismo en este momento no se lo puedo decir, pero está en todos los sitios, se mete en internet y cálculo del peso predicho, que es el peso que debía tener en virtud de la estatura que tiene el paciente.
Bueno, y aquí otra pregunta que nos hacen es si en los pacientes, digo, es una parte que no se tocó precisamente, pero si en los pacientes en ventilación no particularmente entenderíamos quizá que están refiriéndose a pacientes obesos mórbidos, ¿habría algún punto de corte en cuanto a peso o a índice de masa corporal para reconsiderar como una contraindicación relativa la ventilación prono?
Hombre, yo eso no lo sé. O sea, es una pregunta que no lo sé. Yo creo que la contestación un poco así más desenfadada sería que depende de la fortaleza de los enfermeros de la unidad de cuidados intensivos. En principio no tiene que haber ninguna contraindicación. Obviamente, uno de los inconvenientes de la ventilación en prono es que requiere mucha atención de enfermería para evitar complicaciones tan graves como la extubación accidental, que con cierta frecuencia se puede terminar convirtiendo en un motivo de fallecimiento del paciente. A medida que el paciente pesa más, es de más difícil manejo y entonces, en principio, sería una contraindicación relativa, pero teóricamente un paciente con obesidad mórbida, en principio, debía ser, desde el punto de vista fisiopatológico, igualmente un potencial candidato a posición en prono. Pero no se escapa a nadie que cualquiera que esté en una sala de cuidados intensivos y vea a un paciente con 170 kilos, la posibilidad de poner en posición en prono es realmente compleja, es muy compleja. Pero no me sé que haya un punto de corte. El punto de corte probablemente está condicionado por el entusiasmo y la disponibilidad de gente para poder voltear a un paciente, y que es muy complicado. Y luego volverlo a poner en la posición inicial. Yo creo que el problema este es tan complicado como el cambiarle de posición para evitar las úlceras de cúbito y tal, pero realmente no me sé que haya que por encima de 40 no esté indicado y por debajo de 40 sí, o por encima de 30 no y por debajo de 30 sí. Cuanto más delgadito es al paciente, más fácil va a ser ponerle en prono. Pero es un problema mecánico, no es un problema fisiopatológico.
Y bueno, digo, tenemos varias preguntas por cuestiones de agenda de los tiempos. Vamos a presentar a la última pregunta del doctor Andrés Esteban. Si podríamos seguir tomando el mismo valor, las variables, en este caso de protección pulmonar, como la presión plató y particularmente la presión de distensión en pacientes con obesidad mórbida.
Yo creo que sí, porque en el fondo la presión que transmitimos al enfermo es la que importa y que necesitemos subir la presión para conseguir los 6 o los 8 o los 10 mililitros por kilogramo de peso de predicho, pues en principio es lo mismo. O sea, nosotros tenemos que manejarnos con esos parámetros y que, aunque nos cueste en un momento determinado, subir la presión inspiratoria, la presión pico, pero la presión pausa no tiene por qué ser diferente y, por lo tanto, la PIP tampoco tiene por qué ser diferente y entonces yo creo que manejaría al paciente con las mismas características de cualquier otro paciente, teniendo en cuenta que eso que a lo mejor va a ser necesario en obesos mórbidos importantes el tener digamos, que subir la presión inspiratoria. De todos modos, los obesos mórbidos, yo creo que el mayor problema es el médico, porque nosotros cuando empezamos el programa de cirugía bariátrica en mi servicio, el primer paciente que nos trajeron a cuidados intensivos en el posoperatorio, tardamos 2 días en estubarlo, puramente por miedo. Luego los estubábamos sin problema y ahora ya no los traen, los mandan directamente a la planta. Quiero decir que la mecánica respiratoria no varía notablemente, salvo en casos muy extremos, pero es fácilmente manejable y yo recomendaría que lo manejasen con los mismos criterios, salvo que eso, que a lo mejor para conseguir introducir los 8 mililitros por kilogramo de peso predicho, hace falta a lo mejor una presión inspiratoria un poquito más alta.
Bueno, muy bien, doctor Andrés Esteban, queremos agradecerle su valiosa intervención. Esperemos ya en la siguiente sesión de este foro tenerlo ya de forma presencial. Ahora, por las cuestiones circunstanciales de esta emergencia sanitaria, lo hicimos de esta modalidad. Como quiera que sea, esperemos que el siguiente año podamos contar con su presencia aquí y agradecerle mucho su participación, como siempre, doctor.
Pues, muchas gracias al doctor Gutiérrez y a todo el equipo que está colaborando activamente en la logística de una cosa que por ser la primera vez seguro que es más complicada y aunque solo sean durante 30 minutos, encantado de estar en México. Muchísimas gracias.
Muchísimas gracias, doctor. Queremos también, además de darle las gracias al doctor Andrés Esteban, darle las gracias a quienes nos han apoyado en la realización de este curso, particularmente las personas de Aspen, de Baxter, Medtronic y Pfizer. Sin ellos también no sería posible, junto con toda la asistencia de los participantes que estamos teniendo, del público. Y bueno, después de la intervención del doctor Andrés Esteban, vamos a continuar con la agenda. Vamos a tener una plática, es una plática que tenemos grabada del doctor Luciano Gattinoni sobre distintos fenotipos del cuadro clínico de COVID-19. El doctor Gattinoni, al igual que el doctor Andrés Esteban y que pues el resto de los profesores que tenemos agendados aquí, no requiere necesariamente presentaciones. Alguien ya ampliamente conocido, pero bueno, el doctor es actualmente profesor de la Universidad de Göttingen en Alemania y anteriormente se desempeñó en cargos como la presidencia de la Sociedad Nacional Italiana de Anestesia y Cuidados Intensivos, la Sociedad Europea de Cuidados Intensivos y la Federación Mundial de Sociedades de Medicina Intensiva y Cuidados Críticos. Y su línea de investigación se ha dirigido particularmente a lo que es fisiopatología y tratamiento de SIRA, y ha publicado más de 400 artículos de investigación en revistas revisadas por pares. Es miembro honorario de la Sociedad Alemana de Anestesiología y Cuidados Intensivos. Es miembro también del Royal College of Physicians y fue galardonado por el premio Lifetime de la Sociedad Americana de Anestesiología. Recientemente ha tenido intervenciones muy relevantes en lo que es el tema de SIRA en pacientes con COVID-19, sobre todo a partir de la descripción fisiopatológica de estos patrones fenotípicos, y es de lo que nos va a hablar el día de hoy. Entonces vamos a continuar con esa charla.
Good morning to everybody. My name is Gattinoni. I'm very glad to be here and to share some controversies that we have now about this disease, this COVID-19, particularly COVID-19 pneumonia. I think you heard already Professor Slasky, Professor Marini discussing more or less on the same topic. We rose some controversies in our scientific and clinical community. But let's first to see what is the phenotype. Phenotype comes from the Greek, means how something, some individual appears. It's not a religion, it's not a dogma, it's just how a given patient presents in a given time or in given circumstances. Nothing else. It's nothing magic. It's not a can or a bin in which I put the patient A or versus B. It's just a word of communication. And let's see very briefly how the things happen, why we started to speak about this phenotype. as a way of communicating. Let's see, these are the first patient. You have seen these were done by Professor Chiumello. What I present is derives from the experience which has been done in north of Italy and in London, with from a lot come from the discussion with a lot of my previous co-workers. Now I'm in Germany, in which the COVID fortunately had a far lower impact. But look here, these are within the first patient arriving in intensive care, and you see here on the right, the compliance goes from 20 to 90. And the average, or the mean, or the median compliance is around 50. Means that 50% of the patients arriving in intensive care with deep hypoxemia do present a relatively good flexible lung. And look here, the right to left shunt fraction from 30 to 75%. So these patients were terribly hypoxic. Now, in my, let's say, career clinical and scientific career, I worked with the RDS for 40 years. And I have to confess that I never saw so many patients with severe hypoxemia, which may be included as severe RDS, as is classified now. We had so good compliance. So, as the gas exchange is mathematic, there is no way. If I have the gas which is inflate the lung, and the lung is full of gas, and the compliance is the measure of the amount of gas I have into the lung, and I have a deep hypoxemia, the problem must be on the perfusion. And this is an extremely logical. In this series of patients, there are not many other explanations. Look here in this graph. Here is the gas volume of this patient. 1 liter, 2 liter, this is 3 liters. And you see that the respiratory system compliance tell you how much is the amount of gas which is present in a given situation. I think many of you are aware of the concept of the baby lung. That means RDS as a baby lung. That means the size of the lung is the size of the lung of the baby. That means they have a compliance, they have an amount of gas around 500, 600. And the compliance is quite low at that level. But here in COVID, we have not a baby lung. At least in a lot of patients, we still have a good adult lung. Look here, these are CT scan of a couple of patients. This looks more or less as a more typical RDS. This is a little more strange, but look at the PO2 and FiO2. It's 100 millimeters of mercury, exactly 100 millimeters of mercury in both of the patients. The lung weight in this patient was 1.2 kg. The normal lung weight is around 800. In this patient, the lung weight is more than 2 kilos. So we are full of edema, fibrosis, whatever, something which has its own weight. And look at the compliance, 55, 67. I mean, it's difficult to see in what we consider as the classical RDS, compliance like this in patients in this condition of lung weight. So we try first to understand, to make a hypothesis why this happened. And let's see, I think there is an accumulating evidence that the The COVID is basically a systemic disease. The lung is one of the important victims, which is an inflammation within the endothelium. And endothelium has this condition has two clinical important consequences. The first, the hypercoagulability and thrombosis. And now everybody recognizes that we have a lot of thrombosis around. At the beginning, somebody was not believing to that, but this is, now I think there is a quite general agreement of the hypercoagulation in this patient. And the second, if I have an inflammation of endothelium, I have a loss of the vasomotor tone, and I have a VQ mismatch. That means if I have a good and adult lung full of gas, repeating myself, and the hypoxemia is very severe, the explanation is not the right to left shunt, which the classical true shunt through the non-aerated tissue. But this component, the VQ mismatch, which is quite a difficult concept in physiology, but very basically means that the ventilation is in part of the lung, primary in one part of the lung, and the perfusion, which is low perfused, and the other part of the lung has a very high perfusion and very low ventilation. So the blood has no time to be fully oxygenated. And this may create a very deep hypoxemia. And we have some accumulating evidence, and probably will come much more in the future, telling that look at this patient who is full of gas, but the perfusion is completely disturbed. This is one of the first perfusion images of disturbances of VQ mismatch. Remember, it's not only low VQ, it's a VQ mismatch. I may have a patient with 5 liters of VA and 5 liters of Q, so the VQ general is 1, but the mismatch means that all the VA is one part and most of the Q is another part. This is what created the hypoxemia. And this is one example, I don't spend more time on this, on the VQ mismatch. And the only way I can explain 100 of the PO2, FiO2 PO2, in a lung like this, in which the recruitability is almost zero, is only the VQ mismatch. A VQ mismatch, the only explanation is the loss of vasomotor tone, the control of the perfusion. So we have the hypoxemia, no question about that. And hypoxemia has as an effect, when hypoxemia is quite severe, has an effect an increased respiratory drive. But respiratory drive, when you have this inflammatory form, or even in some classical ARDS, is not only dependent on the gas exchange, on the hypoxemia, may be dependent on the cytokine or a lot of undetermined factors that we know that the respiratory drive is increased, although we do not exactly the mechanism of increasing the respiratory drive. But when we have respiratory drive increase, we have an increase in total ventilation, which is mostly due to the tidal volume increase, more than the frequency increase, at least when the problem is the hypoxemia. So most of the patients presenting to the hospital with severe hypoxemia and a PCO2 around 33. Some do not even advert dyspnea. They do not suffer of hunger of air. But why? When dyspnea occurs, dyspnea is a central sensation, is a subjective feeling. We feel dyspnoic when we do not receive as much gas as we expect for the breathing effort we are doing. If I'm doing a big breath, a big effort, and I have a lot of air coming in, I'm not dyspnoic. If I give a big effort but I don't receive, I have dyspnea. As an example, I expect 1 liter of tidal volume and I receive 600, I have dyspnea. If the compliance is good, the dyspnea is more difficult to occur because for that effort, I receive that amount of gas. And several friends, maybe, well, I don't want to take the climbing in the mountains, but there are other situations in which you have deep hypoxemia without dyspnea. But dyspnea may occur also in this patient. And when dyspnea occurs, when the lung flexibility goes down, the compliance goes down. So I make a big effort, but I receive less gas. At this point, I have a problem. So we call, let's see, we observe some patient coming with, I don't say normal, with bilateral infiltrates, but very thin, very soft ground glass, a little bit here, a little bit hard, and no dyspnea. And these patients have low elastance, means high compliance. They have the AQ mismatch, that means they have a low DAQ in some part of the lung, which explains hypoxemia. The lung weight is not normal, but is not so abnormal. Is increased, but not too much, and the recruitability is low. Because if I don't have a big edema, I don't have big collapse. If I do not have big collapse, I do not have big recruitability. Now, let's see, I have a patient like this coming into the hospital. And remember, the disease may evolve very rapidly. And let's see that this patient has a hypoxemia. What the doctor do? They start to give oxygen. And some patient with the oxygen go well. Or maybe they have high flow oxygen. Some patient get CPAP. Some patient get non-invasive ventilation. Good. If this is enough to correct the hypoxemia and the patient is not dyspnoic, there is no problem. We never recommend intubation in these cases because I don't have any sign of particular fatigue of the patient. However, let's imagine that this patient, which is start with some dyspnea or is dyspnoic, I put non-invasive support, and despite a PO2, which may be perfectly regular, I can put in a wake-prone position. But if despite this maneuver, the patient remains dyspnoic, this is a potential factor which further deteriorates an inflamed lung, which is so-called self-induced lung injury. I mean, the ventilator-induced lung injury, if I take an animal and I ventilate a very high ventilation for 24 hours, I kill the animal. Or if I don't kill, I have a very severe ARDS. If I take, I was a Colombo Mascheroni, were taking normal sheep and they were putting some acid in cisterna magna, and the spontaneous breathing sheep start to hyperventilate. In 24 hours hyperventilation, you have a tremendous edema. That means if I leave the patient for days with hunger of air, that means if somebody measures the esophageal pressure, may they find swings up to 20, 25, 30, 35. This is in a terrible condition of stress and strain from the lung. To stop this is the early intubation, not for gas exchange, not for CO2, but to decrease one of the potential damage of the lung. Of course, the lung may continue its course, the pneumonia, its biological course. But we have at least to avoid what we can avoid. We don't have any magic drug to stop the biological course. Cortisone maybe may interfere in part, is discussed. But what we have? We don't have nothing to kill the virus, but we should avoid at least what we can avoid, with the ventilator-induced lung injury, self-inflicted, which is not, as some distinguished colleagues said, a recent invention. If you go back to 1938, we have beautiful papers from Barak, perfectly using and describing the lung damage from self-inflicted hyperventilation. Now, if this continues and is not cured, we have inspiratory effort plus the biological problems, and we have a classical RDS, and we call type H, high elastance, that means low compliance, high right to left shunt because you have a lot of edema, high lung weight because I have edema, and high recruitability. So this is a classical RDS. But this does not mean that the COVID pneumonia have only type L and type H. If you want to play with the words, you can take L plus, H man, L plus plus, whatever. We have a lot of pictures between two extreme paradigms. It is just to tell that depending on the status of the patient, even the respiratory intervention is likely, in my opinion, should be different. And look here. This, as an example, respiratory system compliance and the days from the onset of symptom goes down. The venous admixture, that means hypoxemia, stay there since the beginning. And let me, this terrible example, which was he was a friend of mine. This in the day 2 or 3, deeply hypoxemic, 95 millimeters on mercury, PO2 FiO2, and this was a CT scan. You know, was perfectly aerated. We don't have almost nothing in terms of non-aerated tissue. So true shunt is almost absent. We have a lot of VAQ mismatch. This unfortunately was kept for 4 or 5 days with a helmet CPAP because there were no other places for respirator intubation and so on. And after 7 days of very high inspiratory effort, PO2, same. Look at the CT scan. Now, you can say whatever you want, that the type do not exist, that this is classical RDS. I mean, the facts are there. I think when we have something new, we should not try to put everything in the box we have read in our brain to put when we put previous information. But try to be a little bit open-minded. Of course, nobody discussed that in this condition, higher PEEP is important. Prosupine is absolutely is mandatory. So the classical ARDS in which we have a real baby lung. But what's about here? Doesn't make any sense here to have very high PEEP. High PEEP means here to put 2 liters of gas more to destroy the hemodynamic, to put cardioactive drug in 24 hours to have a problem with the kidney and so on. So the negative pressure, big effort, plus the virus biology, all may interrupt, progress the disease. What we can do? Here we can act. Here we cannot do much. We must have anticoagulation in this patient, in my opinion. So our symptomatic therapy is to keep the patient alive without progression, for what we can do without the progression of the disease, and try to have maintained perfusion in this lung. So, type L. If a colleague of mine called me and say, okay, I have a type L, I immediately realize black lung, bad gas exchange, good compliance. Somebody called me and say, I have a H. I immediately realize white lung, patient with a metal ventilator, tube, positive pressure ventilation, and require more PEEP. Okay, it's just a word of communication. Here, the non-invasive support, of course, if the effort persists, mechanical ventilation. Now, FiO2 as needed, tidal volume. Now, when we wrote somewhere that in a patient with AD of compliance, you can use a tidal volume greater than 6 milliliters per kilo, was a sort of a religion battle. My God. So all the Taliban of the 6 milliliters per kilo rise up. But tell me why I should maybe accept an hypercapnia when I have a plateau pressure of 18 in a patient which has 2.5 liters of gas and the compliance is 70. Tell me what reason I have to do that. You want cholera RDS? Perfect. Because we have some bilateral infiltrates and there are hypoxemia. Perfect. They are under the Berlin umbrella. Perfect. But please don't be so linked to the magic numbers. Respiratory rate, PEEP. In this patient, PEEP, why very high PEEP? We do not need very high PEEP in this patient. Prone position, of course, if you put prone position, you have a VQ mismatch, you improve the oxygenation in this patient, most of them. As soon as you are supine again, no, they resume exactly as they were before. Now, if we have 30 patients like this and we have a few nurses, prone position is a little bit complicated. I would use in this condition as a rescue. But if you want to do prone position, no problem. If you have manpower enough, prone position never create problems. And it creates advantages in terms of survival in patients with smaller lung and greater stress and strain. In this condition, in improved gas exchange, we are happy. If you have manpower enough to put a patient in prone position, okay. If you have in this present situation, as we were in Italy months ago, we don't have time to do that. And so we have to select. And these are the patient FiO2, tidal volume, respiratory rate, PEEP, possibly lower than 15, and prone position in this case becomes mandatory in terms of survival. So there is nothing new. It's just that this is a classical, typical, severe RDS you are accustomed with. Weaning. Now, the weaning may be problematic. Also here we had a lot of discussion. But if we look at the weaning, saying, okay, now I have a very hypoxemic patient, I put a mechanical ventilation, the hypoxemia is correct. Let's see if I am an L patient. And I disconnect the patient, is immediately back in the previous situation. So to wean the patient, the basic disease has to be solved. And if you do too early, the problem of the reintubation may be as high the incidence as 40-50%. Some patient also has some problem with the brain, with the center, with the respiratory center, which may be attacked by the virus. So the weaning is one of the difficult parts of this column. So remember that more than 50% do not have the classical RDS. It's a long-course disease. Patients to be patient in this patient is an important thing. The impression I have that more we try to do, sometimes worse we can do. We have to be very human, to study the patient as much as is possible. I realize that in an emergency situation, the thing may be completely accelerated, more difficult, and so on. But some principle must remain, some principle of treatment. And at least what I try to do is to be patient, not to hurry up in doing something, but before to do whatever you do, think about the background physiology. This is not a syndrome. This is a disease that you are starting to know. Thank you for the attention.
Bueno, aquí concluye la participación, es una participación del doctor Luciano Gattinoni, que es grabada en video. En este módulo, por razones obvias, no omitiremos la parte de preguntas y respuestas. Hacemos extensiva un agradecimiento al doctor Luciano Gattinoni por su colaboración en un tema que además ha resultado bastante relevante desde el punto de vista de la fisiopatología de pacientes con COVID y ha sido también un tema ampliamente debatido. Y bueno, en cuanto a nuestra siguiente intervención, vamos a continuar con Christa Schorr. Antes de eso, quiero permitirme hacer un anuncio de lo que serían las fechas de nuestro siguiente evento, que es el Foro en su edición número 24, el Foro Internacional de Medicina Crítica 2020. Como decíamos, esta es la primera edición que se hace a través de esta plataforma. Esperemos que ya tengamos mejor control de esta emergencia sanitaria el siguiente año. Y la fecha en la que se llevará a cabo el siguiente evento va a ser exactamente los días 8, 9 y 10 del año 2021, si no hay alguna otra circunstancia que nos llevara a modificarla. Esperando que todos nos acompañen o que una gran mayoría de los que nos han apoyado en esta transmisión en línea a través de la plataforma y a través de Facebook Live, de manera presencial, en el supuesto en que sea posible realizarlo así. Y bueno, ahora sí, decíamos, continuando con esta parte del programa, el siguiente tema es de cómo mantener la atención centrada en la familia durante COVID-19, un binomio que ha adquirido relieve en esta pandemia y que todos los que han trabajado en la parte asistencial lo han vivido de forma directa. Este tema está a cargo de Christa Schorr, que es una enfermera clínica que se encuentra adscrita al Hospital de la Universidad de Cooper y profesora asociada de la Medicina de la misma institución en la Universidad de Rowan. Ella ha dirigido la mejora de calidad de la atención crítica y de la investigación clínica y además ha participado en múltiples eventos, tanto a nivel nacional como internacional, sobre sepsis, mejora de rendimiento. Ha sido autora y coautora de más de 150 artículos en revisión por pares, así como capítulos de diversos libros. Ha trabajado además en el Instituto para el Mejoramiento de la Atención Médica y formó parte del equipo que desarrolló el software de mejora del rendimiento en la campaña de Sobreviviendo a la Sepsis. Es miembro además activo del Comité de Fuerza de Trabajo de la Society of Critical Care Medicine, de su comité ejecutivo, y además es jefa de grupo del Comité de Pautas para Resultados a Largo Plazo y Objetivos de Atención de la misma sociedad. Ha continuado además enfatizando en la importancia de la identificación temprana de sepsis, el desarrollo de procesos de atención y la importancia del compromiso del paciente y la familia, por lo que qué mejor para tocar un tema en una situación como la que se está viviendo actualmente. Vamos a continuar entonces con su intervención.
Good morning. Thank you so much for this invitation. I certainly miss being with all of you, but I'm pleased that we're able to complete this presentation online. So my topic is maintaining family-centered care during COVID-19 induced ICU visitor restrictions. And what I'm going to talk about is patient family-centered care, communicating with the family during restricted visiting, and then talk a little bit about a program that we implemented called Critical Call Connections. And I'll share that with you towards the end of the talk. So when we think about patient family-centered care, there are a lot of components. And many of the components not only focus on the family, but also focus on the patient. So patient family-centered care is kind of broken up into two categories, but you'll see that the family is integrated here in patient-centered care. They want information. We need to ensure that we are aligned with the patient goals and that we coordinate and collaborate with the patient and the family. And also important is that the patient's physical comfort and emotional well-being is top priority. The challenge that we're having currently is that the family, in general, we would like to welcome family into the care setting, but unfortunately, due to COVID, we are not able to have family members in the care setting. So that's causing a little bit of a challenge for us. Visiting hours, again, over this past several years, maybe the past 10 years, most of us have changed our visiting hours where we have or try to have very flexible visiting hours and we also have regular family meetings, generally within 24 to 48 hours. And this was developed by a task force, the American College of Critical Care Medicine in 2004, 2005. And again, I think this really helped make the family feel that they were a part of their loved one's care. And it also allowed the clinicians to have good conversations with families. But again, this has been challenged due to the COVID-19 visitor restrictions. When we think about family-centered care, this was a phrase that was coined in critical care medicine in 2017 with the family-centered care guidelines. And it's an approach to healthcare that is respectful of and responsive to individual family needs and values. So again, what we need to do is maintain our ability to be respectful and responsive during COVID, knowing that we may have some challenges meeting all the needs of the family. But what families report that they really need, they want information. So they not only want information about their loved one, but even anticipating, what is going to happen. They also want to be reassured that we are doing everything we can to care for their loved one. You can imagine not being at the bedside. So proximity was a key reported need, being close to their loved one. And during COVID, obviously this wasn't a possibility. So that really put a strain on the family. They also want support and comfort. So again, when we looked at the patient-centered care, the patient's physical and mental well-being were important. And similarly, in family-centered care, they also stress the need to be supported and comforted during this difficult time. And that's in basic critical illness. And you can imagine during COVID, it became a little bit more magnified due to the fact that they could not be at the bedside. So what do families feel during this experience? When their loved ones are in the intensive care unit, family members experience anxiety and or depression, and it increases their risk for development of PTSD or post-traumatic stress syndrome. And again, we talk about communication and how important that is and having family meetings. And one of the challenges is that poor communication between the treatment team and the family causes significant frustration. So we all know that during COVID, the clinical team has been really working hard, spending a significant amount of time at the bedside. Also, trying to learn about COVID. We're not experts on COVID just yet. So it really did cause some frustration for the family because they wanted to be in contact with the clinicians. So maybe the communication wasn't as perfect as one would want, but certainly we are all doing our best to communicate with families. But we also need to recognize this is a very difficult time for those that are home that can't be with their loved ones. And importantly, which clinicians do families expect to communicate with first? So when their loved one is admitted to the hospital, and oftentimes the family member, brings their loved one to the emergency department, and they can't even attend the emergency room visit. So they're basically leaving their loved one in the emergency department and not knowing when they'll be able to see them again or what is going to happen to them. But really what they do expect is that they'll communicate with an attending physician within 48 hours. And this was based on a survey in the Journal of Emergency Critical Care Medicine. Again, there's a variety of multidisciplinary team members that would likely communicate with the family, but the family expects that the attending physician will contact them within 48 hours of being admitted to an ICU. I think this is reasonable and certainly understandable, especially if the patient is critically ill. So along comes COVID. This is a dashboard from our state, the state of New Jersey. And this is a snapshot from about a week ago. And you can see that we did have a significant peak in April and May, and we've kind of tapered off some. So we're pleased with that. And we're keeping our fingers crossed that our social distancing and mask wearing will continue to keep our hospital admissions down for COVID. But again, you can see that we have been dealing with this for several months. I think our first case was admitted in the beginning of March. We still have some cases, but not nearly as many as we had in the past 6 weeks. So when we did have this initial thought that this was very contagious, we really didn't know a whole lot about it. We implemented visitor restrictions like most hospitals around the world. And it really caused a significant change in how we communicate with families and even how families can communicate with their loved ones at home, the patients, how they communicate with their families. So we did have a significant change in our plans. We had implemented a temporary visiting policy, and this was implemented as of March 17th. So our hospital policy is that we have no visitors until further notice, and this is actually still in place today, except for limited exceptions. So if a patient is in hospice or end of life, they are certainly allowed to have a family member with them. There are one visitor support person for maternity patients, and one visitor support person for pediatric patients. In addition, we're allowed to have one visitor support person for a person under the age of 18 who has a disability or is undergoing same-day surgery or ambulatory care. We also implemented a team, a committee, that if there are special circumstances, the clinicians can contact the team related to COVID visiting, and they'll make a determination on whether or not someone can come in to the hospital. And again, it's a challenge because we not only want to protect the family members, we want to protect the staff, as well as other employees as well. So it's a little bit tricky, but I think most of us have been able to implement this and keep it going for the past several months. And we'll see when our visiting hours open up. They haven't quite yet. One of the most significant fears is, unfortunately, some of our patients do expire in the hospital due to COVID. And the biggest fear that anyone really has is the fear of dying alone. And this was a nice perspective in the New England Journal, talking about the fear of dying and what we need to do as far as being very compassionate during this time, and how COVID may change the way we deal with critically ill patients. And this particular quote I thought was really important, that the fear of dying alone is nearly universal, a fact of which anyone who's taking care of a critically ill patient is acutely aware. And I think importantly, if a patient is at end of life or placed on comfort care, it is key that we communicate with the family in a way that either they can come in, one person can come in, and at least be a part of that process, or be able to communicate with them in a very sensitive, comforting way, because it's extremely difficult for them not to be with their loved one during the dying process. And we also ensure that we tell them that they're not alone, that someone is with them, and we're doing all we can to keep them comfortable and safe, and that we are their family while their family is not there. So again, anything that you can do to help support and comfort the family during this time has been really key. Some of the communication methods that we've been using, like most hospitals around the world, we've been using just standard telephones, so our own cell phones or the hospital phones. We've been using iPads. We've been using Zoom on some occasions. One of our clinicians, who's also a pulmonary critical care physician, has also been using the technology that they use in telemedicine to incorporate family members in rounds, if that's a possibility. But again, we've had to become very clever, and I think this is going to change the way we communicate with families, even when visiting hours open up. Maybe this is another method that is going to be really helpful for us to be able to communicate with families. And not only the clinicians communicating with families, but when the patients are awake and alert, they want to speak to their loved one, their family members that are home. So this allows them to see their family member and their grandchildren and those sorts of things. So this type of communication has been really helpful. And I don't know about your hospital, but in our hospital, we certainly did not have enough iPads or smartphones to go around for this process. So we were very lucky to have a large donation from one of our sponsors that donated a number of iPads for our institution. So that was really helpful. Now, caring for patients during this time, we all had significant time constraints, and our volume also was really up. We actually had, during the peak, we had 4 ICUs, all with COVID patients, and it really put a strain on the clinical team. And we actually had to even redevelop who was actually on the team, just so that we could care for these patients. So we recognized the communication with families was going to be very challenging from the start. So one of our clinicians, Michael Coach, who is one of our attending critical care physicians, actually did a literature search on what patients expect and what we would anticipate the limitations are due to COVID. And then we implemented some potential solutions. So if you remember, I talked about the expectations of family, that 98% of families expect to be contacted by a physician within 48 hours. They want the initiation of communication with the critical care team or the treatment team. They also prefer to have at least 2 meetings or 2 calls per day. So we recognize that maybe the expectations of the family was not something that we were able to do initially, and that we were going to need help. Also, the families wanted to be supported not only by the nursing staff, but the clinicians as well. And again, they wanted to be by their loved one. So we recognized these limitations, and we implemented a program called Critical Call Connections. And we worked with our medical students at the Cooper Medical School at Rowan University, and they had an initial contact with the family, and they played actually a supportive role. Importantly is that the initial contact of the plan of care, anything related to end of life, anything related to consent was always done by one of the physicians on the treatment team. So that wasn't the role of the medical student, but they were able to provide support for the clinicians and also support for the families. And again, importantly is that we always wanted to make sure that the family knew that their loved one was never alone, that there was always somebody there caring for them, and we were their family during this critical time. So this is a program that we implemented called Critical Connection. This photo is one of the critical care teams, and you can see the technology that they use. They have medical students in each of their phones. And basically, this is the plan that was implemented. So when a patient was admitted to the ICU, the treatment team called the family within 24 hours and introduced not only the plan of care and discuss the patient's condition, but they also introduced this critical call connections program. The standard rounds would occur, and the medical student would attend rounds on the phone, so they were able to hear what the clinicians were discussing in the plan of care. And then the medical student was given a summary at the end of the round to say, these are the 3 things that we would like you to talk to the family about. The medical student called the family, and they also documented their conversation in a family communication note. And then if the family had any questions, they could document the questions in the medical record, and that was helpful to the clinicians. And the reason why we did this was the medical students were unable to complete their clinical rotations due to the conservation of PPE. So this was a way for them to still be involved with the care at a distance. And again, they were all volunteer students. So we did some training, we did some quality checks during the training process, and we implemented change if we saw something needed to be changed to make the process more efficient as well as more effective for the families. We completed surveys. The students, the families, and the physicians all completed surveys at the beginning of the program as well as the end. These are just some of the results. Each survey had about 10 questions, but on average, these are the students' responses. This is about, we didn't say how much time they needed to spend on the call, but it looks like the majority of the students spent a minimum of 30 minutes, and there were some students who spent more than an hour with families. Again, as far as the communication, the students were trained by one of our palliative care medicine clinicians in how to effectively communicate. And on average, how much time did they spend on family phone calls? I'm sorry, the first number was, the first survey was basically on how much time they spent in rounds. So each student was assigned 2 to 3 patients. So you can see they spent between 30 minutes and 75 minutes. But as far as time on the phone with the family, range between 7 and 90 minutes. We also wanted to ensure in some fashion, or at least measure, whether or not this process was helpful to the students. So we thought that it was going to be helpful to the families and the clinicians, but we also were hoping that the students would get something out of it as well. So the one question was, participation in critical connections helped improve my communication skills, and you can see the majority strongly agree that it did help with communication skills. And it also, in the response in the lower left, on the lower right, we were interested in whether or not this actually impacted or increased their appreciation for empathy and compassion. And you can see just about 92% indicated that they strongly agree that this impacted their ability for empathy and compassion. So I think the skills that they learned will be helpful to them as they move on to residency, as these were 4th-year medical students. So towards the end of May, they graduated, and now they're in residency. These are some other responses from the physicians. And we were curious as to whether or not the medical students' involvement, if that helped, they felt that this helped improve family communication, and the majority did feel that. So 67% strongly agree, while 33% agree. The documentation in the medical record was unbelievable as far as, what they talked about, what questions the family had. So if the clinician at the end of the day was going to call the family, they could easily review the documentation from the medical students, and that would actually give them a foundation for the conversation, so they knew what the medical student talked to the family about, and it really was helpful. And one of the questions was the EML or documentation helpful to the family when they called the family, when the attending physician called the family, and 100% strongly agree. Some of the family comments, so I had the opportunity to talk to more than 40 family members. As far as the communication, we wanted to make sure that we were doing the best that we could during these challenging times. And not only was the clinical team doing a good job, but also to see if our program related to medical students was helpful. So overall, the family members were very satisfied with the clinical team's communication, and they were also very satisfied with the medical students. Some of the quotes here, they said that the students provided helpful information and shared the questions with the physicians. I came to expect the call each day around the same time, so there was a consistency that the family members valued. The students, some of the words that they used to describe the students included kind, knowledgeable, understanding, compassionate, and helpful. And the information that was provided was in a way that they could understand. And I think that's really helpful because the fourth year medical students, you know, they haven't really done any residency. They're still learning as well, but they were able to communicate in a way that was helpful to the family. So we thought that that was really valuable. So in the end, we thought that this program really helped us quite a bit. And the program ran from April 6th until the students graduated on May 26th. And then after that, the residents picked up this responsibility for calling. But again, our numbers of COVID patients have decreased. And so the stress level on the clinicians has subsided some, even though we still have critically ill patients, but not to the same degree. So I'd like to thank all the student volunteers. You can see we had just about 20, a little over 20 students who volunteered for this program. And we also had a team of clinicians who oversaw the program, wrote the protocols, and basically came up with a program that we thought was going to be helpful. So we thank those that participated in this program. Moving forward, I just want to give you a thought of, you know, how we perceive families. So I know initially I said that the visitor restrictions, but it really made me think, you know, should family really be considered visitors? Or should we call it something different? So I want to leave you with this because I thought that I learned this during COVID, that maybe family isn't visitor. They're not visitors. Maybe we should be moving towards family presence or family engagement as opposed to calling them visitors, because they are so much part of our clinical team. They know a lot about the patients, and they want to be a part of our team. So I want to leave you with that, and how family presence is extremely important. So I thank you so much for your time, and I wish you the best on the rest of your conference. Thank you so much.
Muy bien, agradecemos a la enfermera Christa Schorr su excelente participación. Este ha sido un tema que yo creo que ha sido una preocupación para todos nosotros, de cómo manejar la situación actual con la familia del paciente. No siempre es fácil. Sabemos que en la mayoría de nuestras unidades de cuidados intensivos y a veces en el hospital, en todo el hospital, no están permitidas las visitas, están restringidas las visitas de la familia, y pues de alguna manera hay que mantener la comunicación, porque obviamente el nivel de estrés en esta situación para la familia es elevado. Hemos visto en las noticias, en los medios sociales, en las redes sociales, eventos muy desagradables en algunos hospitales en nuestro país, y obviamente que la comunicación efectiva con la familia será una manera de tratar de atenuar ese nivel de estrés que hace que a veces las cosas se salgan de control. Vamos a tener la última presentación de nuestro evento, el primero virtual que tenemos. Antes de ello, quisiera yo agradecer a todos los asistentes a este evento, que sorprendentemente pues tuvimos una gran cantidad de registros en la plataforma, de tal manera que fue necesario abrir un canal, el Facebook Live, para poder seguir las pláticas. Así que hemos tenido una gran participación de la audiencia. Eso lo queremos agradecer, debido a que sabemos que sobre todo ahorita los médicos intensivistas pues están muy ocupados con las labores que hay que hacer en el hospital, y el hecho de tener una gran respuesta a esta invitación que hicimos recientemente, pues eso nos satisface mucho. Obviamente esto también nos anima y nos compromete para continuar con esta actividad académica, y como lo anunciaba ya el doctor Fernando Campos, estamos listos para el año que entra. No sabemos todavía la modalidad en que esto pueda llegar a ser, dependerá de la evolución y del rumbo que tomen las cosas en el siguiente año, pero definitivamente estaremos presentes también en el presente año, en el siguiente año, ya sea de manera presencial y si no, pues de manera virtual también. Estamos en espera de poder conectarnos con el doctor Phillip Dellinger, que es nuestro siguiente invitado. Para mí es un honor presentarlo a él. El doctor Phillip Dellinger es profesor de medicina y académico distinguido de la Escuela de Medicina de la Universidad de Rowan. Es además asistente senior de cuidados críticos y director del Instituto de Investigación de Cuidados de la Salud en la Universidad Cooper. El doctor Dellinger es un viejo conocido de nuestro curso, prácticamente año con año ha estado apoyándolos en el mismo. Y el doctor Dellinger es autor también de más de 250 artículos de revistas y capítulos de libros. Sus principales intereses académicos están dirigidos a las nuevas terapias innovadoras contra la sepsis, el manejo de la sepsis y la mejora del rendimiento de la sepsis. Es editor asociado de la revista Critica Medicine. Él es expresidente del Foro Internacional de ese consejo. Fue el autor principal de las directrices internacionales de la campaña de supervivencia a la sepsis en 2004, 2008 y 2012 sobre el manejo de la sepsis grave y el choque séptico, y es el autor principal de las directrices de esta campaña en 2016. El doctor Dellinger ahora nos va a presentar un tema, como todos en este simposio, muy importante, acerca de las reflexiones sobre pacientes con COVID-19 críticamente enfermos, la experiencia aplicada desde el frente clínico. Esperemos si está listo el doctor Dellinger para iniciar con su presentación. Doctor Dellinger, muy buenos días, muchas gracias por su participación en el foro. Adelante.
Your slides, but I'm going to
Dr. Dellinger?
Balthazar, can you hear me?
Yes, we are ready, doctor.
Good to see you.
Thank you.
Should I go ahead and start?
Excuse me?
Should I go ahead and start?
Yes, please.
Okay.
For you. Thank you so much.
Yeah, it's great to be back with my friends and the meeting I'm used to participating in every year. It's just a little different doing it virtually this year. My talk topic is thoughts on critically ill COVID-19, gray hair from the front line. Let's Proximo. I have no disclosures. Proximo. This looks like I'm seeing Dr. Schorr's presentation. Or someone's. Yeah, Baltazar, that was someone else's presentation that came up on my screen.
Okay.
What were you seeing?
I'm seeing you. Okay. Now
So
we can
advance approximal.
Dr. Dellinger, we can see your presentation.
Yeah, but can you advance the slide?
Oh, I will see.
Okay, now that's my presentation. Can we advance the slide?
Yes.
Okay, now we're rolling. So just wanted to let everyone know what it was like with COVID here at my hospital in Camden, New Jersey. At the peak of the surge at Cooper, which was May, we had 65 COVID patients on the ICU service. 35 were mechanically ventilated, 6 on ECMO, and 4 separate ICU services devoted totally to COVID. It's very different here. We have 5 mechanically ventilated COVIDs now from the peak of 35. Next slide. Next slide. So what I'm going to do over the next 25 minutes is I selected 3 areas that I wanted to express my own opinions and reflect on some of the literature, talk about anticoagulation of the critically ill COVID patient, patient self-inflicted lung injury or PSILI. And when we think we have seen it here at my hospital, and a method of mechanical ventilation that might be particularly useful in COVID ARDS called time-controlled adaptive ventilation, or TCAV. Next slide. Starting with anticoagulation, next slide. What we know about D-dimer in the critically ill COVID patient is that it seems to be consistently elevated across most critically ill COVID patients. It's often very high. In fact, we have seen a few here at Cooper that were greater than 20 milligrams per liter or 20,000 micrograms per liter, which is above our lab's ability to measure. And I think this was one of the first laboratory findings that we observed that might have made us think that these patients were going to have problems with clotting. Next slide. This is an anticoagulation algorithm from early on in COVID. This is in mid-April from Mass General Hospital, and it looks like this doesn't project very well, but I only wanted to use it to say that early on, we really didn't think any differently with these patients. Even with the D-dimer, I think it didn't change our anticoagulation habits. Next slide. What we then began to see at Cooper, I think the first thing that made us think that we were going to have procoagulation problems with these patients is when our first COVID patients went on dialysis, we were having a tremendously difficult time dialyzing because the clots that were forming in the dialysis machine, and even when we fully anticoagulated these patients, it in some patients continued to be a problem. Next slide. And then we observed what seemed to be a higher incidence of macroclotting, of deep vein thrombosis and pulmonary embolism. This particular, you can see the pulmonary embolism shown on this CT pulmonary angiogram. Next slide. And when we started getting patients on ECMO, we would have problems with clotting of the oxygenator in the ECMO. Next slide. And this is a subcostal view showing the liver at the top of the slide and the inferior vena cava at the bottom. And this is an ultrasound image taken immediately after decannulation, which we do under ultrasound guidance in a patient that was coming off ECMO. And in the inferior vena cava, you can see the clot on the upper wall. Next slide. And then we begin to see autopsy reports of microthrombi in the capillaries and small vessels in the lungs in the autopsy specimen that were far greater than what we had seen in the typical ARDS patient in the past. And this microthrombi, the extensive formation of microthrombi in the small pulmonary vessels, might be a reason we are seeing some of the pulmonary artery hypertension and some of the RV changes. Might also be a potential explanation for the contributor to the severe hypoxemia in patients that do not have a lot of parenchymal lung disease with COVID, perhaps combined with ineffective hypoxic vasoconstriction. Next slide. So what did this mean at Cooper at the time? Since we were seeing all this clot and we were seeing these very high D-dimers, some of the faculty, we did not develop a policy where we would fully anticoagulate all patients with a certain threshold of D-dimer if there was no contraindication. But I think many of us did begin to switch to fully anticoagulating patients, perhaps with a D-dimer threshold of 3 milligrams per liter or 3,000 micrograms per liter. Next slide. But that was done without any evidence-based medicine and without any publications to support that decision. There is now a publication in the form of a letter looking at the New York experience of 2,773 COVID patients in New York City, the effect on full dose anticoagulation on outcome. Most of these patients were put on full dose anticoagulation based on very high D-dimer levels. The data was adjusted with Cox adjustment for age, sex, body mass index, ethnicity, heart failure, AFib, type 2 diabetes, and admission date. Next slide. And this was comparing patients that were on full dose heparin with those not receiving full dose heparin. And you can see these are survival, Kaplan-Meier survival curves. The red curve are the fully anticoagulated patients, and you can see that survival was significantly better in the patients that were fully anticoagulated. This was particularly on the right, this was especially prominent in patients that were requiring mechanical ventilation. Now, one of the limitations of this study is that this is all retrospective data. This is not a prospective clinical trial. The other limitation is that it's not adjusted for severity. Next slide. And I think when we consider full anticoagulation in COVID patients with high D-dimers, I mean, obviously, if there's clot present, if they have pulmonary embolism or deep vein thrombosis, we're going to anticoagulate these patients. But what we're talking about is anticoagulating prophylactically because of the possibility of developing clot or for potential pulmonary micro thrombi. This study recently in a pre-proof looks at 33 COVID patients with intracranial hemorrhage. Can you go back one slide? Almost 67% of these patients that had intracranial hemorrhage were on therapeutic anticoagulation. A little less than half of these with super therapeutic anti-10As, 9% prophylactic heparin, and 6.1% presented with intracranial hemorrhage and a diagnosis of COVID having been on home anticoagulation, and 18% not anticoagulated. Next slide. So these are some examples of some of the more prominent hemorrhages that we're seeing. There were also quite a few patients that did not have such serious hemorrhage, but it was the cause of death from herniation in 5 patients. Next slide. So it's always best when we're trying to figure out a new disease process to participate in clinical trials. And we now have that capability, and our plans are to participate in a trial, antithrombotic therapy to ameliorate complications of COVID-19, the ATTACC trial, ATAC, which will randomize patients to full dose anticoagulation versus prophylactic anticoagulation. Next slide. I'm going to move on now to patients' self-inflicted lung injury and PCILI and how that might be applicable to our critically ill COVID patients. Next slide. PCILI, patient self-inflicted lung injury, was first described in 2017 and published in the Blue Journal. Now, this description of PCILI was in mechanically ventilated patients with ARDS. Next slide. And as you can see on this slide, the bottom of this graphic display shows that these are 3 tidal volumes that are all the same, with controlled ventilation, spontaneous breathing, and what is called partial assist breathing, where the patient is contributing to the generation of the tidal volume, but you're also seeing positive pressure provided as well. So when you look at the second row, you can see that it's all positive pressure. On the far left, it's all negative in the middle, and it's less positive pressure on the far right, and some negative pressure, but not as much in spontaneous breathing. And the point that's being made here, and I think we first realized that this could be a potential issue when we had the first paralytic study in ARDS that showed better outcomes, and one of the reasons postulated was that it may be bad to have significant patient inspiratory effort early in ARDS. And this is a similar thought process. Next slide. So this was the figure from that study, looking at patients with established ARDS, in which there would be increasing respiratory drive, leading to increased respiratory efforts, increased esophageal pressure swings, increased transpulmonary pressure, and the potential for inducing further lung injury due to the high transpulmonary pressures. Next slide. So this is a COVID application of that principle, in which the increased esophageal pressure swings, the increased respiratory efforts, and the increased tidal volumes that these might be created. And these are in patients that don't have to be intubated. These are patients that can even be on high frequency nasal cannula or on non-invasive ventilation. The potential for these patients to have high respiratory efforts, high inspiratory efforts, and generate high transpulmonary pressures that could potentially be damaging. Next slide. So for an example, I know Professor Gattinoni lectured earlier in this meeting, and I'm sure you've been introduced to the L phenotype, which are patients that present with minimal parenchymal lung disease, but very prominent hypoxemia. What we found, the potential in these patients is that if these patients are allowed to have high transpulmonary pressures and generate higher tidal volumes, the mechanical power that's created from these high inspiratory efforts may be a contributor to developing worsening parenchymal lung disease. In other words, if you let the patient have too much respiratory effort, you'll generate significant mechanical power, significant transpulmonary pressures, and potentially injure the lung and drive the parenchymal disease forward. Certainly there are other reasons. It could be due to inflammation resulting from viral stimulation or actually viral propagation itself. Next slide. Our experience at Cooper that makes us concerned about PCILI in non-intubated COVID patients is that we have received quite a few transfers from outside institutions where patients were allowed to, in attempts to try to avoid intubation, patients were maintained on high frequency nasal cannula or non-invasive ventilation, and review of charts indicated that they were allowed to have quite a bit of respiratory effort. So these patients, in order to try to avoid intubation, were allowed to have high respiratory work or breathing for significant periods of time. And by the time we got these patients, they now had diffuse parenchymal lung disease. And the question of whether a major contributor that was allowing these patients to go with such high work of breathing, when perhaps it would have been better to intubate the patient, sedate the patient, and take away that work of breathing. Next slide. The last thing I want to talk about is time-controlled adaptive ventilation, or TCAV. If you look at the pressure over time waveform, you'd say, well, that looks like the pressure over time waveform for airway pressure release ventilation. And it does, because TCAV is airway pressure release ventilation. It's just a particular protocol that's applied to the use of the APRV. Next slide. This is just a representative case from the Cooper experience. This is a 34-year-old male with the COVID-19 ARDS, this whiteout of the lungs, very poor compliance, very difficult to oxygenate. These patients are more often than not either already on ECMO or headed for ECMO. This would be the prototypical example of the H phenotype that you've already heard discussed earlier, the patients that have diffuse infiltrates, a lot of parenchymal lung disease, very low compliance. Next slide. This is a more familiar airway pressure release ventilation graphic display. At the top, you can see pressure over time. You can see the period of time when the pressure is high. The P high is the pressure, the T high is the time of the higher pressure. And then you can see the drop in pressure to the P low or the low pressure for what's a very short time called a dump time to allow CO2 elimination and generation of auto PEEP and total PEEP. The green line on the top of that graphic display represents what we typically don't measure in patients on APRV, but it's the alveolar, the pressure in the alveolus, which is always higher than the pressure that can be measured at the end of expiration because you still have expiratory flow. The second graph that you see is the flow over time, and you can see the inspiratory flow on top, which reestablishes the P high or the high pressure, and then you see the expiratory flow beneath the x-axis, which is stopped after a brief period of time to generate auto PEEP and therapeutic PEEP. And if you look at the bottom, you can see what the flow over time looks like, and it's magnified somewhat. So you can see at the start of expiration, when you're going from P high to P low, you see the drop in expiratory flow over time as the gradient for flow decreases. On the right, you see what that looks like for ARDS with a steeper curve. There's more rapid expiratory flow because with ARDS, the lungs are very stiff. And when I talk about time-controlled adaptive ventilation, or TCAV, it's setting the T low, setting the time for the low pressure, which allows expiration, targeted toward adjustments over time to maintain 75% of the initial peak expiratory flow at the end of expiration. So you start out with a peak expiratory flow on this particular graphic at the bottom, it's 60 liters. And then when you stop the T low and you repressurize the system to high pressure, you try to keep that at 75% of the peak expiratory flow when you end T low. So why would you want to do that? I'm going to explain it on the next slide, but I also wanted to say that there are animal studies that would indicate that a 75% stop time for T low gives histological findings that would indicate the best limitation of stress and strain in the lung. Next slide. It's important to understand that the lungs have communications between the air sacs that allow air to move from one air sac to another. And this is still preserved to some degree in ARDS. Next slide. And this creates what's called viscoelasticity, demonstrated here. If you pressurize a diseased lung along with bad ARDS, if you look at the graph on the left bottom, you get continued recruitment of lung over time. And you can see that with open lung represented on the x-axis, you get a lot of initial opening of lung, but you still continue to get recruitment over time. You can see the red line continues to rise throughout time with this inspiratory pressure application. And then with expiration, you see on the right a rather initial steep drop in open lung with de-recruitment. And the trick would be, or the application of airway pressure release ventilation in severe COVID-19 ARDS, as I demonstrated on that previous chest radiograph. If you have a long application of positive pressure to the lung, as we do with P high, and then you have a very brief expiration, as I showed you with T low, you can continue to recruit lung during P high, and then with the short expiration, you can prevent significant de-recruitment, and you have the potential to keep and hold more open lung in a patient with severe ARDS with COVID. Next slide. So guidelines for initial TCAV, APRV settings in a patient with severe COVID would be an initial P high of 30. And we're not going to let these patients breathe spontaneously. I know those of you that use APRV realize that one of the potential advantages is the spontaneous breathing that can occur on P high in a patient that's not sedated. You certainly would not do that in these severely ill COVID ARDS patients. So if you set a P high of 30, you're going to limit plateau pressure to 30. You could allow a higher P high in an obese patient. Obviously, some of that P high is needed to push out the chest wall and abdomen. Initial T high of 5 seconds, it gives you about 12 respiratory cycles a minute. An initial P low of 0, which gives you the highest gradient for expiratory flow and allows you to achieve a therapeutic PEEP with the minimum amount of T low. And as I mentioned, the whole thing about TCAV is to set end expiratory flow at 75% of initial peak expiratory flow. You got to start somewhere. So starting at 0.5 seconds would be a reasonable start point. Next slide. So in summary, we talked about anticoagulation. We still don't have any high level evidence, but because of all the clot that we're seeing in these patients, both at autopsy and the micro and macro circulation, as well as the very high D-dimers. The rationale for empiric anticoagulation in the absence of DVT or PE is there. I still think we need randomized controlled trials. So if you have the capability to participate in a randomized trial, that would be my recommendation. We talked about patient self-inflicted lung injury, a little different, I think, in COVID, where it may have the most relevance in patients that are not intubated and sedated, that don't have a lot of parenchymal lung disease. And then finally, a protocolized version of APRV, time control adaptive ventilation, that may be of value in optimizing recruitment. Next slide. Thank you very much. A protocolized version of APRV, time control adaptive ventilation.
Hello, Phil.
Hey, Juan, good to see you.
Good to see you too. Thank you very much for being here with us. It's lovely.
Thank you very much.
So we will start the questions. I have some questions from the audience. Some of them are quite difficult. Let me know if you think these questions are outside of your sphere. But one of the things that we found that you are in advance, you have experienced things that we are not yet in that moment. So we love to hear from you a little bit of your experience. So for example, how much fibrosis have you seen in your patients? And I know it's a very short time from the moment when you finally was able to relieve them from the ICU and send them to the hospital. And we are still learning about this disease. But what is your experience in this moment about the outcome of the patient from the lung perspective? Whatever you have seen, understanding that you are not really completing the follow-up of the patients necessarily. Relieve them from the ICU and send them to the hospital.
Yeah, so are you hearing the same echo that I'm hearing, Juan?
Yes.
Okay, I mean, I can still understand. So in answer to your question, curiously here at my hospital, despite having what seemed to be a very prominent experience with critically ill COVID, our hospital established a policy of not doing autopsies in COVID patients, which we wanted to do. I can understand concerns. So what we have is a clinical diagnosis of fibrosis. These are patients, we had some patients on ECMO that did not survive, that were out like at 30 days, even high 30 days, approaching 40 days of ECMO, that had just thick, white, non-compliant lungs, had compliances of like 9 mLs per centimeter of water, that just had to be fibrosis. It's just that we didn't have a confirmatory diagnosis. We did have one patient that had a CT scan diagnosis of fibrosis. So we thought we were seeing it, but we couldn't definitively diagnose it. We actually gave steroids to a few patients late in the course of ARDS, along the lines of what was done in the ARDSNet Lazarus trial, the Maduri protocol that was intended to prevent fibrosis. When we thought we started to see patients going into that, now we know that it looks like the use of steroids is probably most appropriate used early with 6 milligrams of dexamethasone a day. But that would appear to be treating inflammation and not prophylaxing against fibrosis.
Okay, thank you very much. The next question, Phil, is, would you take dead space that you can measure in your patient as a surrogate to believe they have pulmonary thrombosis? And thinking about this, start anticoagulation in full treatment?
I would, you know, and we have, and I think that makes sense. I think decisions to use empiric anticoagulation would best be made based on having a very high D-dimer and elevated dead space. Remember that ARDS itself is associated with increased dead space, but I think if you're seeing increased dead space in that type L phenotype, if you believe in the phenotypes, and some people do and some people don't, but that L phenotype with the high D-dimer and a high dead space, that would make sense for empiric anticoagulation.
Okay, thank you. So next question is regarding, have you heard all these type of combos that everybody wants to give? They, for example, ascorbic acid, thiamine, zinc, and I guess we run into the problem when we think that we need to do something and we feel we are short of options and we put everything on the table. So there's different ideas about giving not just dexamethasone, but some people will give methylprednisolone, ascorbic acid, thiamine, and full heparin. What do you believe your best guess regarding these type of combos, or would you suggest a very specific treatment according to each patient?
Yeah, we don't use any of those homeopathic therapies or any of the therapies where there's no physiologic data to support it and there's no evidence-based medicine. I'm sure since I'm the last speaker in the program, you've decided now that remdesivir makes sense to give. I think every patient should be on remdesivir if it's available, and I think obviously the earlier the better. The problem is predicting which patients are going to get worse. I think until we see the peer-reviewed publication of the 6 milligrams dexamethasone, it still makes sense to use that just based on the data that we've been allowed to see. I think therapeutic anticoagulation, if you can enroll your patient in a clinical trial, makes sense based on the discussions we had. I think enrolling in a clinical trial would be better, but I'd say no to zinc and no to vitamin C. And now we stopped giving hydroxychloroquine, but now there's another study that sort of may shift our thought process back in the other direction. So that's very controversial.
So I have two different questions in the same sentence. It's regarding anticoagulation. So the first question is, what is going to be your best suggestion regarding how do we start anticoagulating our patients? And the second one is, as soon as they are outside of the ICU, do you continue anticoagulation for how long? And with which type of option do you choose for home anticoagulation?
Yeah. So obviously we don't know the answer to that question. So it's just a matter of what we're tending to do here at Cooper. Here at Cooper, if we felt like that there was a temporal improvement in COVID critical illness related to the use of empiric anticoagulation, we would continue it for 4 weeks.
Perfect. There's another question from the audience, and this question I totally understand is we're trying to figure out from the experience of different persons and faculty that has been here, and some have shared with us their own experience in their local ICU. So regarding your ICU at Cooper Hospital, how frequently did you have co-infections or bacterial infections apart of COVID? So it was something very frequently, you had a lot of problems with multi-drug resistance, or in your case, specifically in your hospital, this wasn't present?
Yeah, we definitely saw more secondary bacterial infections in our COVID ARDS patients than we saw in our typical ARDS patient. You know, it's observational data, it's anecdotal. We are collecting data, so we will eventually be able to know the answer to that question. But you know, during the height of the COVID surge here at Cooper, we had two Zoom conferences a week, WebEx, with all the faculty that were available, and just talked about what we were seeing and developed sort of a group thought process. And it's clear that most of the attendings felt that they were seeing a lot more secondary bacterial infections. And at that time, we were also giving quite a bit of anti-IL-6 therapy, tocilizumab. And there was also a feeling that patients that got the anti-IL-6 therapy seemed to be more likely to get the secondary bacterial infections, although again, that was just observational, anecdotal type data.
Dr. Dellinger, once again, thank you very much for the effort to be here with us, for your participation. We always enjoy your lectures, and it's always nice to hear from your experience and that gray hair. What is the best proposal for the treatment? Okay,
yeah.
So
and
Juan, we'll need to.
I apologize too. I've been so impressed with the people that were running your audio visual and the Zoom hookups. It's a great bunch of people. In fact, what the audience doesn't know is that my screen share failed about 5 minutes before I was supposed to go on. And we ended up having to, what we call in English, jury rig my presentation. So I was unable to screen share my presentation. And the reason I mention that is that so I was not able to use my pointer. Mm-hmm. So a lot of these complicated slides that I had, you know, I would have been able to explain them a lot better if I had the pointer instead of having to just tell you what part of the slide to look at. But it's been a great experience always. I just got a nice text message from Professor Dominguez, and Juan, it's good to see you, and Baltazar, and look forward to, my plans are to come to Mexico as soon as I am able, independent of your meeting.
You know, you're always welcome here, and everybody here is our friend. So certainly, our team from BTC has done an excellent job helping us to gather everything together, and these things happen. So I will say goodbye for my part, but Dr. Baltasar will continue here with the audience. Be safe. Best regards.
Thank you.
Muchas gracias al doctor Dellinger por su excelente presentación. Gracias también al doctor Juan Gutiérrez por la coordinación de sesión de preguntas y respuestas. Y bueno, pues esta fue nuestra última plática de este 23 Foro Internacional de Medicina Crítica en este 2020. Con este terminamos el foro, y solamente para cerrar quisiéramos agradecer a todas las personas que han hecho posible el desarrollo de este foro, obviamente a la gente que año con año ha estado participando con nosotros, como es la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey en el campus Ciudad de México. Queremos también agradecer al Consejo Mexicano de Medicina Crítica, que año con año nos proporciona el aval para este curso, y que eso pues obviamente permite o ayuda a la recertificación de los médicos especialistas en medicina crítica. También queremos agradecer a los patrocinadores del foro, a Aspen, a la Baxter, a Medtronic y a Pfizer. Estas empresas son las que hacen posible también el desarrollo del presente foro. Estamos muy agradecidos con ellos. Esperemos que para el año que entra también podamos contar con su participación. Queremos agradecer también a la empresa BTC Américas, que han manejado de una forma excelente la plataforma virtual de este foro. Nosotros que somos viejos y que somos novatos en esto, creo que solos no lo hubiéramos podido hacer, así que muchas gracias también a ellos. Un agradecimiento, obviamente, a los participantes, que ha sido, como lo mencionaba anteriormente, una participación muy importante de ellos. Hemos tenido en nuestros sitios alrededor de 1,800 visitas, más de 4,000 reproducciones de las presentaciones que ha habido. Han ocurrido 97,000 interacciones en nuestros sitios virtuales, con más de 380 preguntas que se han realizado durante el desarrollo del foro. Entonces, pues eso también lo queremos agradecer, porque definitivamente pues todo el esfuerzo está dirigido a la comunidad médica que se encarga del tratamiento de los pacientes gravemente enfermos, y particularmente en este año a esta pandemia que afecta a todos por igual. Queremos avisarles también que las constancias de su participación en este foro estarán disponibles a partir del viernes 17 de julio, del próximo viernes. Ahorita aquí vamos a dejar un link, aquí pueden ver un link en pantalla en el cual pueden descargar la constancia. Y finalmente, ya para despedir esta actividad académica, pues reiterarle la invitación para el año que entra. El año que entra tendremos el Foro Internacional de Medicina Crítica 2021 en su versión 24 ya es muy mayor de edad este foro. La invitación queda abierta para los días 8, 9 y 10 de julio de 2021. Agradecemos nuevamente la participación de todos ustedes, y mientras nos volvemos a ver, por favor, cuídense todos, manténganse seguros, manténganse cerca de la familia. Muchas gracias y que pasen un buen fin de semana.